Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher, and today is June 4th, and our topic today is going to be medical decision making. So I spoke about E&M history and exam in episode 82, and today in our episode 84, I wanted to really just focus on some medical decision making and really kind of bring that to the forefront. There's a lot of confusion when it comes to the overall risk table. Now, this is not a training session, so I never want to turn the podcast into that. It's more of just a learning discussion, and then hopefully at some point you'll want to get the tools you need to be proficient in some of the topics that I bring to you and take a webinar. So first of all, can you believe that we are halfway through 2019? I know I can't. So we're already into June. Hope everyone had a good month of May and is looking forward to June with graduations, vacations, good weather, and hopefully only positive vibes. So what we want to look at, again, is the driving force of the E&M service. And when I talked about, just making you listen to this in a form of, okay, so now I get it. I kind of understand where she's going with this. But we want you to continue your education. And if you're a physician or you're a coding staff or an auditing staff, we want you to feel confident in what you're doing and hopefully doing it correctly. But remember, I provide these free podcasts for you so that you know how to basically take the information and then say, okay, I feel comfortable with this person, and now I want to register for an educational webcast or seminar or training session. And sometimes you don't get to sample the product before you try it. And so consider this your sample. You get to decide, am I comfortable with what she presents with Terry and with the information and her references? Everything's about an authoritative reference and a source. So hopefully that's what you're taking the podcast for. And again, I appreciate everyone who's listening in. We're just hit 57,000. So we're doing pretty well there. Also, hello to my listeners of the week, Rachel in Louisiana, Karen in North Phoenix, and Suzanne Burmeister. She comes from us from North Carolina, and she also brings us our coding question today on general surgery and lymph node excisions. And I'm actually going to talk about that this morning before I get into my topic, just so I don't forget, because my topic's going to take a little bit of time. So something came up with the code, and it's a new code for 2019. It's in general surgery, 38531. And this is an excision or biopsy open of an inguinal femoral lymph node. And so you must know how the MD removes the nodes, the anatomical site, and the extent of the lymph node removal. So for example, the 38531 I mentioned describes an open inguinal femoral biopsy procedure, while the codes, if you look at 38760 and 38765, those are for inguinal femoral resection procedures, and they could be considered more extensive. Now, those procedures also have what we call a separate service designation after that, or I should say separate procedure. And so you also might have some pushback if you're trying to bill for more than one line item with one of those codes. So make sure that you are perfecting your general surgery coding when you're looking at some of that information so that you can be as accurate as possible. And we want to thank Suzanne for that question. Today's Codecast question was brought to you by PACOM, Professional Association of Healthcare Office Management, PAHCOM.com. So as I talked to you a little bit about the medical decision-making process, I want to bring up just some information because there's mistakes that are very common when you're scoring, if you're an internal auditor or if you're just looking to see if the physician met that particular level of service. So let's take a look at, so first I want to look at some mistakes because that happens all the time, especially when I'm doing my audits. And I just want to kind of bring to you some of the most often mistakes I see with some tips on how to avoid them. So one of the things is listing the problem without a plan. So as coding staff, you may be able to infer that what the acuity or the severity of a case is without, superfluous or redundant documentation. But as an auditor, they may not have that ability. So adequate documentation for every service date. This helps to convey patient complexity during the medical record review. So although the problem list may not change dramatically from day to day, or during a hospitalization or for follow-up visits. As an auditor, we only review the date of service in question. So we're reviewing what's in front of us, not the entire medical record. And a lot of doctors, I notice when I comment, when they try to get to a level 5 and they say, well, if you look back, I'm like, stop yourself right there. It's not my job to look back. It's your job to bring forward. If it's pertinent to the medical record or to the encounter of the day, that is your job to make sure that I have a complete description of what you're doing and the effect of that description. So physicians should be sure to formulate a complete and accurate description of the patient's condition with a plan of care for each encounter. They want to listing problems without a corresponding plan of care. That doesn't corroborate physician management of that problem, and that would downgrade the complexity, in my opinion. So if you list problems, for example, let's say with basically a brief generalized comment that says DM, CKD, CHF, which would be diabetes, and kidney disease, chronic kidney disease, or congestive heart failure, and then just put continued treatment plan, that, in my opinion, can diminish the complexity and effort put out by your physician. And so clearly document the plan. The care plan represents problems the physician personally manages, along with those that must also be considered when he or she formulates the management options, even if another physician is primarily managing the problem. So for example, let's say in the hospital, if a hospitalist can monitor the patient's diabetic management while the nephrologist oversees the chronic kidney disease, since the CKD, so the chronic kidney disease, impacts the hospitalist's diabetic care plan, the hospitalist may also receive credit for any chronic kidney disease consideration if the documentation supports a hospitalist-related care plan or comments about that disease where it doesn't overlap or replicate the nephrologist plan. So there has to be some value-added input by the hospitalist in that situation. Established problems are less complex than new problems for which a diagnosis, prognosis, or care plan has not been developed. Severity of the problem also influences the complexity of a problem. So if you say worsening problem, that's considered more complex than an improving problem. And those are your basics. Just remember, your worsening problem will likely have your physician requiring more revisions to the current care plan, and that means more physician effort. So you should always identify all problems managed or addressed during each encounter. If anything's stable or progressing when appropriate, any kind of differential diagnoses if the problem still remains undefined. Make sure that there's some management or treatment options for each service because I need that detail and I need to know why there's no changes and, medicines, why you're personally managing and why. A lot of things come up in the medical decision-making about prescription drug management, and this is really kind of interesting when we get there. So I want to address that because that's probably the biggest thing I see overcoding with. But first, let's look at the relevant data. So data is organized as pathology, laboratory testing, radiology, and then medicine-based diagnostic testing that contributes to diagnosing or managing a patient problem. And so pertinent orders or results may appear in the medical record, but most of the background interactions and communications involving testing sometimes are undetected when I look at the progress note. So if you want to receive credit for your data reviewed, specify tests ordered and rationale in the physician's progress note, or make an entry that refers to another auditor accessible location, even though that would not be my first choice. I would want to make sure that it was part of that medical record. And then document test reviews by including a brief entry in the progress note. So you can say elevated glucose levels or chest x-ray shows RLL infiltrates. Credit is not given for entries lacking documentation. If you just put chest x-ray reviewed, I skip it. So it has to be a little bit more information. Also, if you're summarizing old records from someplace other than the patient or someone other than the patient, then you'd have to say something like, outside hospital records reviewed and shows. Give me an information paragraph. Records from previous hospitalizations reveal. When you indicate that you're looking at tracings or images or specimens, you want to show that they're personally reviewed, or I'll just assume that you're reviewing a written report. And you also want to comment on the findings. If there's any contradictory test results or anything that's unexpected, make sure you also include that as well. Now, when we look at the patient risk, okay, those are categorized as minimal, low, moderate, or high based on pre-assigned items pertaining to these problems. So diagnostic procedures ordered and then management options selected. Now, chronic conditions with exacerbations and invasive procedures can offer more patient risk than acute, uncomplicated illnesses or non-invasive procedures. Stable or improving problems are considered less risky than progressing problems, and conditions that pose a life threat to the patient or their bodily function outweigh undiagnosed problems where it's difficult to determine the patient's prognosis. Now, medication risk varies with administration. So you want to be clear, oral versus parental. You want to have type and potential for adverse effects. Medication risk for a particular drug. So if it is, increased, decreased, if you say continue without change, it's hard to give credit for moderate because there's no details usually with why, just no changes in, medications. That's really hard to kind of acknowledge that as a moderate risk of medical decision making. And it's controversial because some auditors will give it, I won't. So I want to see more detail on what's going on there. And we have the flexibility. If you've ever seen anything published from any auditing tool or anything from Medicare or what they're talking about, especially from Selma Verna, that is really stickler for some of this information. She gives a lot of leeway to auditors to, kind of pick and choose their way through the medical decision making. But if you look at some of the official rules for looking at medical decision making, basically, we're trying to really quantify the physician's cognitive labor. So, Medicare has discovered that we are having as auditors a hard time really kind of nailing it down when the physicians are not clear on some of their words, or they don't say things more than extensive. They don't give us information for that. So an example of a self-limited or minor problem, let's say on problem points, may be a common cold or an insect bite. An established problem refers to a diagnosis which is already known to the examiner. So you might have hypertension or osteoarthritis or diabetes. An example of a new problem with no additional workup planned could be a new diagnosis of essential hypertension, or and then examples of a new problem with additional workup planned may include a new clinical issue, which requires further investigation. Could be chest pain, anemia, shortness of breath. Problems that are not being addressed specifically by the physician during the encounter may still be counted if they significantly increase the complexity of the cognitive labor required. So here's what I mean by that. So let's say, for example, there is a patient with diabetes who is being evaluated by a vascular surgeon for a lower extremity revascularization procedure. It would be appropriate for the surgeon to include diabetes as an established problem stable when calculating the problem points. And this is because the comorbidity of diabetes significantly influences the risk of the procedure and the complexity of the postoperative management. Okay, so problems are defined relative to the examiner, again, not the patient. If the problem was previously known to other physicians or to the patient, it's still new to you as the physician, you as the provider, if you're seeing the patient for the first time. Also, the physician should be aware, now we get into data points. They should be aware that no double dipping is allowed, and I see this a lot. So, for example, if you review lab results and order labs during the same visit, you only get 1 point, not a point for ordering and a point for reviewing. And the same rules apply to imaging studies or other medicines, such as EKGs or PFTs, function studies. Commonly overlooked points are those used for obtaining or reviewing old records. So if you do review old records, you must summarize your findings in the chart. Don't just say old records reviewed. I'm doing a big audit for a practice ongoing, and I've been doing it for a couple of years, and we do it weekly. So I get probably about 300 records a month for a client. And it's just interesting because the doctors, and we train them and let them know, you're going to get extra points, and I can help support your higher levels if you're telling me that you're reviewing old records, if that's what you're doing. They're like, oh my gosh, we absolutely are. Patient comes with a stack. But then the only entry I see is old records review. Well, summarize it for me. Why is it problem pertinent to today's encounter? Otherwise, that's going to be a problem. Also, notice that points can accumulate quickly if you personally review an image, tracing, or specimen. you can still claim these points even if the image tracing or specimen has been reviewed by another physician. So let's say when a radiologist provides an x-ray interpretation, but you have to include your own interpretation in the report for me to give you points for that. And then we look at cognitive labor when we're talking about the point table for risk on a patient. So let's say, for an example, suppose you see a patient in the office with stable diabetes and suboptimally controlled hypertension. So after checking routine labs, you decide to increase the patient's lisinopril. Okay, I always have problems with medicine pronunciation. So lisinopril from 10 to 20 milligrams POQD. If you calculate the individual points and assign a level of risk, the medical decision making would look like this. So straightforward complexity, you only have one data point because you reviewed labs. And then you would have, for 3 problem points, you'd have 1 for diabetes, established problem, 2 for hypertension, established problem worsening. Okay, so for your problem points, you'd get 3. And then moderate risk due to management option because you do have prescription drug management, because you did actually increase for treatment a medicine on a patient. So, and actually after checking labs, that's managing and prescription drug management. So many physicians kind of can underestimate the value sometimes of the overall risk on a patient, but I'm seeing mostly anytime they say, medicine as usual or no changes, they want to take that prescription drug management, one element on the risk table, and say, okay, I've met the criteria. And that's not always the case. So be, pretty cautious with that. Otherwise that can become a huge issue when it comes to making sure that you're compliant with your medical decision-making portion of your entire medical record. A couple of things I wanted to bring to your attention, and actually it just got posted and published this week. Medical Economics and the World Health Organization came to a consensus, and let me see or find my piece here. So they now say that burnout is now considered to be an international classification of diseases. So it's going to be part of ICD-10-11. It's not going to be part of ICD-10. So everybody said, oh my gosh, now burnout, according to the World Health Organization, is now going to be a diagnosis, for patients. I'm like, well, the decision, it added burnout to ICD-11, which is right around the corner. That's coming out in 2021. And right now for the US, we still use I-10. So we're not sure if this, decision is going to affect how we code now. But here's what they say is going to be added. So physicians can issue a diagnosis of burnout if a patient exhibits 3 symptoms: feeling depleted of energy or exhausted, feeling mentally distanced from or cynical about one's job, and problems getting one's job done successfully. Okay, is anybody right now feeling like, seriously? I totally get the burnout, because in our profession, and especially the physicians, that is considered one of the most burned out professions out there. And there's ongoing and a wide range investigation to determine the causes of physician burnout. But we know what it is. They're hours they keep and the occupational stress that goes with it, and patients and family, etc. But I'm looking at this burnout symptomatology, and they're saying it should only be diagnosed specifically in the context of work and occupational issues, and should not be applied to describe experiences of other areas in life. Well, I see the work comp carriers going, we're not going to adopt ICD-11 after we see that, because you could have a patient that can see that and just hate their job, but that's the only job they can get, and all of a sudden say, okay, I now have burnout. It's a medical condition from my employment. And this is going to really cause some issues. I'm not saying that it's not important to recognize that there is a phenomenon on burnout, but to recognize it as an actual diagnosis, I'm thinking that this is going to open up a can of worms. So I don't know what all of you are thinking, but this is going to be truly interesting when we get back to really understanding what's going to happen with I-11. So I wanted to bring you my personal tidbit today. And actually, I really appreciate the feedback I get from some of my personal tidbits. I get a lot of shout outs from you as listeners, and you're all saying, oh, I love the personal stuff you say. Some of it is really funny. Yes, my life is really funny. And I'm actually going to extend that this week and show you my petty side. So I try not to be petty. I know that we all try not to be, but there's some times that you just got to put it out there. And so one thing that's been driving me crazy this week, it's when I have people in my life, whether professionally or personally, that do not pay attention to the little things. So if you know that I'm a Starbucks iced tea drinker, which I've put that out there a couple times, a lot of you know that, know if I like it with or without sugar. Do not bring me one with sugar. If you know me at all, that would make me mad. It would just be like, well, thanks, but you weren't paying attention. Or if I'm meeting you after work for a flight of wine, please don't ask me if I'm getting the flight of the day if it has a white option in there. I hate white wine. I hate it. I mean, it's just, I don't get it. I'm only drink reds. So I've had that happen to a couple times, and you look at people and just go, you've known me for 15 years and seriously, that's what you're doing? Now, here's one that probably is my most petty, and I have a feeling I'm going to get some cards and letters on this. But if you send me an email to my work, which again, I appreciate you all, but my email address is Terry, Terry, Fletcher, Fletcher, CPC at AOL.com. Shouldn't you spell my name right? I'll get people that will send me emails, existing or new clients or anybody, and they'll send it to my email address, and then they'll address, hi, Terry, Terry, Terry. I'm just like, people pay attention. It's in my email address. It just shows you care about that person. I don't know if any of you've noticed, but when you email me and you have either an ethnic name or an unusual spelling. So Rachel, I know I shouted you out. You've got an extra A in your name. I've seen Tony with an I, Allison with one L. I've seen Michelle with one L. So, if you have something like that, I really pay attention so that I show that I care about who you are, and I'm looking at who you are. So, it just shows that you're paying attention, and it's something that you should just be aware of. Just, some people, I'm trying not to say that it's petty, but I don't know. And then the last one today, I'm shouting at my daughter. So if any of you've listened to my Bun Life podcast, we actually stopped recording in January. I've had I don't want to call it a change in personnel, but I guess that's what it is. So switched. I don't have a certain person in my life who I was doing co-hosting with. So now my daughter and I are picking it up again, and we just recorded a couple of episodes that you'll hear shortly. But we just basically have a ton of fun. It's all about positive vibes, and it's really just a great show. And so you'll see it if you download the Bun Life podcast. You can find us on Twitter, and you can also find us on the web at thebunlife.com. But here's one that goes out to my daughter. And if you think I'm being petty, then that's fine. But here's the thing. If you change the empty roll on the main bathroom toilet paper, or if you empty it, I should say, can you put a new roll on it? Put a new roll on the friggin' toilet roll. Okay. No, what she does is she puts the new roll on the counter and leaves the empty one there. Or she forgets to grab new packs at all in the closet. Or my favorite is she sits the roll sideways on the empty roller. Okay. Yes, I'm having a morning. My pettiness side came out today. So I apologize to all of you who are having a better morning, but I'm just wondering if you have any of those people in your life. And my daughter's 24. She is awesome. I adore her, but she brings out my pettiness. I'm just telling you, if you have any moments like that you want to share, send them over to me and I'll shout them out in my other podcast. We just relaunched, and we're really excited to get those up and aired in about a week. It's pretty funny daily life stuff. So thank you for attending today. Thank you for listening. Make it a great day, and we'll see you next time on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.